for miniskirts and the like, they used to wear, because if you watch their pictures, you could see they were wearing the miniskirt and the one we call pantalon. You see the men will wear some trousers with a very big mat and all that. But for eyelashes, I'm not very sure about that. But this time around, becoming almost a routine. You go to classroom and the women have eyelashes. Some of them, when they are entering the lecture theater, that one is the one that leads the way into the entrance before the whole body follows.
Hello, wonderful viewers. Welcome to our Bridge series. Bridge stands for bringing research into diagnosis and guiding expertise. Each year, hundreds, if not thousands of research work is done in our various laboratories and our universities. However, most of it just stays there and it does not become information that is available to people outside these universities. At the same time, we have clinicians, doctors, who could benefit from some of this work that we do in our various universities in helping their patients. The Bridge series is there to literally bridge the gap between the laboratory and our clinics, and also to make this information available to you, our public, so that you can use it to help guard your eye health. Today, we have with us one of our prolific researchers, Professor Samuel Kyei, who will be talking to us about one of the interesting work that they have done so far. Their work has looked at the effect of extension eyelashes in women and how this affects their eye health. Professor Samuel Kyei, you are welcome.
Thank you very much for the opportunity.
Prof, can you please give us a quick overview of the work that you did?
I guess a very important and interesting avenue to be able to, let me say, degrade. I will put it as degradation. Degrade the complex things that normally we write and get stuck behind paywalls. People don't get to know them. This whole research has been a kind of journey which we have traveled through for some time now. In the space of Ocular surface, we have been doing some work since 2017. In fact, the first attempt to estimate the prevalence of dry eye was undertaken among undergraduate students here in the University of Cape Coast. That was when we realized that even among young people aged between 18 to 35 years, we had a prevalence of 44.3%. Meaning if you take the youths, we have about 43.3% of them coming to the clinic with such complaints. So that one did not end there. Our colleague from Kyei University, led by one Dr. Kobia, is a junior colleague in Kyei University. He also, together with his team, took this experiment or this study further in 2021. And in 2021, their work was slightly different from what we did in 2017, which was published in 2017. What made their work a bit different from our own is that they rather expanded the age group. We did it among the youth, that is 18 to 35. But theirs was from 18 to 90 years.
Okay.
And they got a prevalence of 69.3. That gave another layer of evidence to indicate that this condition is very predominant or is common among our people. But now if you compare the year group that we dealt with and the year group that he added on, you realize that it means that the condition is no better among the youths, if you really look at it from that angle. And there were a lot of associations that we could draw from that particular study. In the work we did in 2017, which was led by Shedu, we realized that environmental conditions do play a role in the kind of dry eye that we do have, ocular surface disorders we have. We realized that air conditioning, that is when we are, whether you stay in an air conditioning room, the humidity, and then also whether the environment is windy or otherwise, all of them do contribute to the condition. And then what was another issue was the fact that people who have allergies, people who come to the clinic with itchy eyes and the like, well, the itching also do contribute to the condition. Okay. But there was something that was not conclusive, because in one dimension of the analysis we did, we realized that stress was linked up with the condition. That is when we did the univariate analysis. So when we look at that parameter against the disease, we realized that in fact, sex was significant. So being a female was a risk or was a probability. We had a higher probability of having the condition. But interestingly, when we did a multivariate, that did not show any significance. But in Kyei study, apart from all the things they also did, they realized that being a female was a risk factor for dry eye if you're a female. And in our work, we realized that the use of oral contraceptives and all those kind of things were also risk factors. And normally, when it comes to our part of the world, the gender that normally uses contraceptives are females, especially the oral ones. For the men, apparently, if they are using contraceptives, they will use the barriers. They are not going to take any medication for that matter. So the women will normally take that particular medication. So it means that some of the practices themselves even put the women at risk. As far back as 2012, my supervisor, may he show rest in peace, Professor Prof, conducted a study among beauty salons within Kumasi metropolis. And they realized one interesting thing that the women who undertake this kind of lifestyle practices like this eyelash extension tend to complain of a lot of discomfort with their eyes, some of them including itchy eye discharges and ocular discomfort and all that with their eyes. That was in 2012. That is about almost 15 years down the line. Okay. But around that time, when the women were asked, because we are having all these negative challenges with the practices or with all these beauty things, would you want to stop or disengage in this particular thing? They said about 65% of them said that they will still continue with the same practice. So that apparently led us to continue in that particular domain. In fact, in Nigeria, Eden et al. Has also conducted some study among undergraduates with respect to this same eyelash extension. Hans et al. Also did the work in China with the same thing. But the issue we have had with the series of experiments or studies that have been done is that this group of researchers, all of them relied mainly on the patient-reported symptoms. So it was just what the patient says. Interestingly, they were not doing anything wrong in the sense that dry eye or ocular surface disorders have been deemed as or tagged as a symptomatic disorder. Meaning, when the patient comes to you and the patient tells you that I have this condition, we trust what the patient is saying more than the clinical testing. Mm-hmm. Because in a study that we did recently in 2018, that one was a study that I led, we realized that there's a very big disconnect between the symptoms of dry eye and the clinical signs. Meaning somebody will come telling you that I have dry eye, that is the symptom the person is indicating to you. But when you do the clinical testing, it may not support what the person is saying. So interestingly, that's even led to the development of what they call the symptoms questionnaire. So that when the person gives you positive indications on the symptoms, it is enough for you to now begin to ensure treatment or begin some treatment of a sort.
Okay.
So given all this, what we try to do was that given the disconnect between the dry eye or ocular surface disorders and the symptoms, we said that, okay, after the people have then told us or reported to us that they have the dry eye, can we go ahead and then measure the symptoms in clinical parlance? That is, we are going to do the T-BAT, we are going to do the stemma, we are going to do almost all the testing that we need to do. And then once we are done with that one, we see whether this time around there's any kind of correlation between dry eye or ocular surface disorder. When we talk about ocular surface disorder, indeed, we are not looking at only the tear. So we are looking at the eyelid, we are looking at the entire ocular surface. That is, we are looking at the interaction between the tear and then the cornea surface and all that. So when we look at it from that particular angle, you now realize that we are not only looking at the tear itself and we are looking at the eyelashes and all the adnescence of the eye. That is how the whole issue came about. And when we did that study, that is why I decided to just pick up some few things from there. When we did that study, actually we tried to pick up people who have been engaged in this practice of eyelash extension at least for the past 1 month, if you have been involved in any of such kind of practice for the past 1 month. Mm-hmm. And people who don't engage in that, and all of them were females, within the same age bracket, okay? And then we took 208 of those who engage in eyelash extension wear and those who do not engage in eyelash extension wear. And these were the findings, that's the overview. It indicated that the findings indicated that the eyelash extension wearers reported higher rates of watery eye. You see that they will be there, they say that there's water dripping down their cheek. And those people who have been wearing the eyelash extension had a higher reportage of that one. In fact, the actual statistics is that 38.5% of those who wear against 21.6% of those who do not wear.
Really?
And when we ran the statistics, it was very significant. It indicated that the numbers or the reportage among those who do not wear or who do wear is higher than those who do not wear. Apart from that, because they are attaching an artificial eyelash to their natural eyelash, they tend to lose the natural one. The natural one, which is supposed to serve as the base for the attachment, sometimes is lost. And normally that one, they call it alopecia. That is lid alopecia. That one looks like somebody losing his hair.
Okay.
So the people tend to lose those hair. And when it comes to the natural loss or the loss of the natural eyelash, 17% of those who practice that one tend to lose their eyelashes as against 9.6% of those who do not wear eyelash. When it came to discharges, because there is a lot of manipulation that happens with the fixing of the eyelash. The beautician will have to hold it, and sometimes one of the things we realize is that they even use some kind of to fix it. They are fixative. They use it to fix it to attach to that one. And those things are likely to cause a lot of infection because with time, the fixative begins to degenerate and then they melt. They get into the eye and cause irritation and sometimes get the eye infected. So when we did that one too, or we asked them, or we checked that one, we realized that 7% of those who wear the eyelash extensions tend to have discharges against 1%. So only 1% of those who don't wear have some kind of discharges. And that one too was significant. But one of the very striking findings was that those who do have the eyelash extension wearers had 22-fold higher likelihood of a reduced T-bat. The T-bat has to do with the stability of the tear on the eye. Their tears are not very stable. And so the time it takes for when you put a fluorescein, that is a dye on the eye, for you to break apart, theirs was faster, okay, because their tears were not stable. And then those who do well also had 83-fold likelihood, okay, of developing eyelash abnormalities. And then again, they were also 3-fold higher likelihood of meibomian gland expansion. The meibomian gland expansions are glands that are found in the lid of the eye. And they are the ones that produces the oil layer or the oil that normally will be the uppermost covering or uppermost part of the tear, so that it will prevent the tear from being evaporated quickly. But if you check it in all the instances, the people who wear the eyelashes tend to have, let me say, very precarious situation when it comes to the assessment of some of these things. In terms of meibomian gland dysfunction, they were at risk. In terms of T-bat, that is the stability of the tear, they were at risk. If it tend to come to even the same thing they are trying to elongate, like the eyelid, the eyelashes, they tend to lose more of it than even retaining what was already there. So that is the overview of the study that we conducted. Thank you.
Thank you. All right. So, Prof, what problem did you see that you were trying to solve with the research that you did?
Thank you very much. We realized a lot of lifestyle changes so far with our women. I would say that the lifestyle changes isn't with the women alone. Now, we tend to use more of digital platforms. In fact, even with the advent of COVID and all that, we were introduced to things that we were not used to before. You can be sitting with a computer and be talking to nobody, and that is deemed as you having a lecture or something of that sort. Now we realize that, because of this social media influence and all this TikTok and all the attendance issues, and then the fact that our women are now also consuming everything, we realize that there are some issues that has to do with lifestyle that tend to also impact on the ocular health of people. So you realize that one of them that we have been tracking and the studies have been consistent with has to do with the wearing of the artificial eyelash. So what we wanted to do was to really look into the health or the ocular health impact of these lifestyle changes. I'm not very sure how many of our grandparents wore eyelashes. I'm not very sure. I won't be able to hold grief for them because I wasn't there. But we had the privilege of watching their pictures. As for miniskirts and the like, they used to wear, because if you watch their pictures, you could see they were wearing the miniskirt and the one they call pantalon. You see the men will wear some trousers with a very big mat and all that. But for eyelashes, I'm not very sure about that. But this time around, becoming almost a routine. You go to classroom and the women have eyelashes. Some of them, when they are entering the lecture theater, that one is the one that leads the way into the entrance before the whole body follows. So whilst we are looking at that one, we wanted to look at it. If they tend to have any negative health implication for them, then it will be a good evidence to be able to advise them or educate them. Sometimes when you go about telling them that this thing they have some negative effect on your ocular health, they may not accept that one wholly, except to provide hard evidence to indicate that no, this is what we have found among our own cohort, and therefore there's a need for us to do something about it. So that is what is really prompted that one. We have a lot of things we can change, or there are a lot of them too we cannot change. One of those we think we can easily change or readily change has to do with lifestyle. If we do a little bit more of effort and people get to know the negative consequences, we tend to then reduce the disease burden of our country as a growing or as a developing nation. That's what made us to go into that.
Very interesting, Prof. So what surprised you about your findings in the work that you did?
Thank you very much. You remember in my overview, or in trying to give an overview of the study we did, I did mention to you one of the very striking things before ITAR found. In fact, I was part of the before ITAR study group. And what actually happened was about 65% of the people with all the discomfort indicating that they will still continue with it. Interestingly, a similar question was asked to our participants. And I'm saying that this is about 15 years down the line. And this is what really happened. What really happened was that about 38.9% of our participants said that they will continue. Given all that we are talking about, they will still continue with it, but they won't stop. And then 32.2% of them were undecided. So assuming those people who were undecided, even if half decide later to continue, then we are still getting to the same 60-something% to 50.
So that would still be for every two ladies, one of them.
Exactly. Because this why if you even put all those who said they were not decided, they were not sure. In addition to that, there are about 70%.
7 out of 10.
Yes. And so if we then want to play fair and say, okay, half of them who said they were not decided at the time, decide later that they want to discontinue. And even half also decide. That half are going to add, that is going to be about 15 or 16% on top of the one, 38.9%. That is still about 50-something%.
60%.
So it means that we have a lot of work to do. People feel like looking more beautiful is worth
the trouble
that comes along with it.
So now, what should we stop doing?
That's a very big question. What we should stop doing is something that I'm even reluctant to say, but because lifestyle, or lifestyle related, if there's anything to be stopped, then we must do away with that lifestyle. That comes with those consequences. So ideally, I would say that if it is possible, as much as it depends on you, that is how the Bible will even put it. If we can keep our natural eyelash, I think our women are still beautiful in their natural eyelash. In as much as I wish that would have been, if wishes were indeed horses, I believe everyone would, right? But the truth is, some other people still in our study said that they would continue with it. So if there's anything to stop, then it means that we have to stop what brings up or what is the trigger. It's what we have to avoid. And the trigger is the friction of the eyelashes. So if we have anything to stop, to avoid all those complexities, that is fine. But I'm not sure how that is practicable. Things are deteriorating so fast, then maybe they may now begin to consider their position of not wanting to to discontinue with the practice. So these are the things that I think we need to do. As optometrists too, as optometrists, those of us in the optometry, ophthalmology, ophthalmic nursing, and the like, what we are doing our assessment, because of the discordance between the symptoms and the signs, what we see that the signs mostly correlate with the clinical symptoms, that we may want to probe further. That is, we shouldn't just take it as a routine thing, because this condition is very common. Like we are talking about prevalence of 44.3 among students, and even 69.3 among the general population as it were. That study actually was done among eight administrative regions of Ghana in the various capitals, and that's what came up. So it is a very common condition. So you are likely not to give it that necessary attention. But when we see those things, we must probe further and ask whether the people are engaging in any of these things. And it's not too difficult to also see, because when the person comes to you and the person is wearing, you know where the person is coming from. But sometimes they might have just removed before they came in there. So you need to just do a lot of history taking to be able to position your patient and empower them to be able to take charge of their own eye health.
Prof, now this leads us to the next question. What do you think we can start doing if we can't stop everything that we need to stop doing?
Now, there are some few things that I think we must start doing, and the things we have to start doing are plenty. For me, number one, we now need to make sure that we do a lot of education. We need to educate our people for them to understand. These are choices, and people have to be faced with the realities that if you go through this path, these are the consequences. I know that people will still choose to probably go that particular path. Heaven and earth have been placed before, but I believe people have obviously chosen her. And I don't think that we have any cause to blame them. So I think that what we can do is to intensify patient education or customer education. Number two has to do with regulation within the space of cosmetology, or those who are into beauty, beautification and whatever, salons and whatever. For me, my thinking is that in other places, if we talk about cosmetology, it is a whole field of study, and people are regulated, licensed. You will be certified before you can do the things you are doing and all that. There is another bit of it about the product, where the Standards Authority and then the FDA and other things might make sure that the items or the products that are coming in are not allergenic. For some of them, it is the product themselves that are causing the irritation because of the kind of fiber they are made of. And like I indicated, the glue that are used for the fishing can also cause a lot of issues. So for me, in as much as probably we haven't advanced as a country to be able to train a lot of cosmetologists who can come under regulation by either the Ally Health or any other regulator as the system may deem it fit, the people who are already engaged in it must be also given some kind of incentive training. They should be trained. They should be able to also admonish their patients and their clients about the do's and don'ts. Because we realize that most of the issue also comes with the care practices that pertain to that particular domain. And then with education, we're also saying that for those people who are very addicted or very adherent to the practice, that it's so difficult for them to detach from it, we may have to admonish them to be doing routine eye examination, more routine than what is recommended. We will say that depending on how old you may be, we may say once a year. Sometimes we say twice, once every 2 years. But for them, I'm not sure whether the once a year would be okay. I think that they may have to do it routinely, because some of them, the moment they remove, they are going to fix the next one.
And finally, Prof, what does this mean for us here in Ghana, in Africa, and in other countries which we regard as low resource setting countries?
Okay. Thank you. It looks like, for me, our continent is also consuming what is on the table. What I mean by that is that there's nothing like this is African. We have also entered into the global market. And whatever items and products are there, we are all consuming it. So our health issues will have to be addressed within the global context, so that we don't make it look like we are in Africa and therefore these ones are alien to us and the like. Maybe it will be alien those days, but this time around, they are rapidly changing demographics. The taste of our people are changing. And so as Africans and as practitioners in this part of the world, we must think locally and relate globally so that we'll be able to meet the demands and the needs of our clients very well. Because we're here, we're saying that, what is this? We to eyelash, when did eyelash become an issue? But because our people are consuming, now we are in a global village, so whatever thing is there are people who don't even drink water from Ghana. They import their water from elsewhere, and they've been consuming those things. So I think that now we do not have anything. We need to make sure that our treatment is within a global context. Again, we also then need to make sure as Africans that we continue to safeguard our cultural practices. You know, this was lifestyle we are talking about. It's change in taste that is bringing these challenges. But at first, apparently, people who were advocating modesty, simplicity, and those things. So it means that we may still need to, even though it's health we are talking about, we may still go back to our background, our cultural background, so we can preserve, conserve, and then defend our various cultural norms with pride. Because this was what nature gave me. I'm proud of it. I do not need any extension to make me more human or to make me more beautiful, because we believe that we were born with all these natural attributes and we need to preserve them. So these are some of the things that we may be losing some cultural clip, and those are the things we need to look at. If we do not do that, the implication for us as Africans and also as a low resource setting is that we are increasing our burden of disease with very little resources to take care of them. So even if dry eye is only giving us, or dry eye is giving us almost about 70% of all the kids that come to our clinic, that's a problem. And I think that if we're able to take out some of these things that can easily be modified, these are modifiable risk factors, then we are likely to reduce the prevalence of dry eye and then the burden of disease as a whole. Otherwise, we'll end up using our hard-earned resources to be taking care of our people, which probably we could have used that same resources for other things. So these are the things that I think are the very, let me say, implications, diamond. Some of them are diamond implications for our continent. No matter how small it may be, they just a drop from here, a drop from there, a drop from there. They all come together, and at the end of the day, we have to spend money on them. But if we're able to change and then shift a bit, then we are able to save ourselves and also save the nation that kind of money that would have been channeled into some of this care. Thank you.
Thank you very much. It's been a wonderful time and a pleasure interviewing you today. Any closing remarks in the next 1 minute or two?
Okay. My closing remark will be that the first thing we'll have to go to people who are or who will get opportunity to watch us. The very things we do requires a lot of support, that is resources, for us to be able to provide the evidence that is needed to support policy. And those of us in Africa, sometimes we tend to have a challenge. I remember one time it was said that African president apparently went into a meeting and decided to commit 1% of GDP to support research. And the last time I checked, Ghana has not even been able to achieve even 0.5 of that. The country that has been able to do a little over 0.5 is South Africa, and yet they have not been able to do the 1%. I think that these are very important evidence that will inform practice. And for me, I think that stakeholders must also be very much interested in this. The last one will have to go to our participants. That we did this thing not because we wanted to just put out information, but apparently what we intend to do is to make sure that we make their life better. So we want them to take up these recommendations and then act on them. Practitioners must also be well informed in their practice so that they will not treat issues as routine or business as usual, but rather they will now begin to add a touch with know that no, if I'm taking care of a patient of this particular cohort or category, then they may have additional needs that needs to be attended to, other than treating them as any other person. Thank you very much.
Thank you very much. It's been a pleasure. We hope to see you again.
Thank you for having me.